Good afternoon. It is that time again. It's 4 o'clock Mountain Time, which means 6 o'clock on the East Coast. I'm Dr. Randy Fink, and this is Fertility with Fink and Friends, live from CNY Fertility in Colorado Springs. I am also the medical director at the Miami Center of Excellence and CNY Fertility at the Miami Center of Excellence, a wonderful place for monitoring. Just like Colorado is a wonderful place to come and get pregnant, and it is great to see everybody this Tuesday afternoon, as we always do at 4 o'clock p.m. Mountain Time. And I see, gosh, everybody is joining in. Jody O, nice to see you. What a pleasure. What a surprise. And Tailored by Taylor, who has some very happy news to share with us. I hope I'm not spilling any beans there. Well, let's see who was the first one to join. Stephanie, welcome and thanks for being there. And I see my beautiful mother and father are here live from the great city of Mobile, Alabama, who are with us, as well as the Salustio family, La Familia Salustio. Glad to see you. On the CNY side, it looks like Andrea DLMT. I'm sorry if I'm mispronouncing that. You are number one. Thanks for being here, as well as, oh gosh, Azure loves animals and Sea Beauty 2 Cutie. I like that one. That's a nice name. Let's see what else we have here. Kathy Hall, Grace, my friend Grace Tung, and Brock. Nice to see you. Jay Villiana, hello, and nice to see you this afternoon. Solin010 has her first fertility consult tomorrow, so that's very exciting for everybody. And over here on the Facebook side, Tamisha is here. Hello, it's nice to see you this afternoon. Chronically Ill Mama, boy, that's a good name. I have to say that's a good one. Should I worry about abdominal discomfort and soreness 2 months after an ectopic pregnancy? No, not so much. I mean, there's usually not something after an ectopic that is going to be a cause for long-term concern. When we have an ectopic pregnancy or a tubal pregnancy, there's one of a couple of different things that can be done there, my friend. We can sometimes we'll treat with medication. That medication is called methotrexate. Methotrexate is dosed kind of based on your size, based actually on body surface area, which we're able to calculate. And methotrexate as a medication will cause a tubal pregnancy to end. A pregnancy that's in the fallopian tubes can't continue because if it tries to grow, it will rupture the fallopian tube and will ultimately cause you to potentially to bleed to death. Most of the folks with a ruptured ectopic end up in the emergency room as a result of pain. But that's one of the things that we really want to watch out for, because of maternal death in the United States. Many of the maternal deaths that are reported actually happen in the early first trimester with previously unrecognized pregnancies that may be in the fallopian tubes. So something we watch out for. So methotrexate is one option. We can make an incision surgically in the fallopian tube and remove the pregnancy, or we can actually just take the tube out. Most of the time we recommend now that just taking the tube out because the tube was damaged to begin with. And so by removing the ectopic, we're really leaving a damaged tube behind, which substantially increases the risk for a future ectopic. But having had any kind of surgery or any kind of procedure there has the potential to, can cause some scar tissue. And so my guess is that's probably what you're feeling there. Well, it's about 5 minutes after the hour on Tuesday, and you're on with Fertility with Fink and Friends. I am Fink. You are Friends, and it is so nice to see all my friends. We've got two different Instagram feeds. We've got Facebook and LinkedIn and YouTube right here as well. So as always, we're going to try to get to all your questions today. I apologize for last week. We had a wonderful, wonderful visit with Jody O from embryology, and I got really such fantastic feedback on Jody's for having Jody here, and she is a wonderful addition to our team at CNY Colorado, and is just a great person as well. great feedback. I had all kinds of questions, and I had intended, and I said, if you listened, I said, I'm going to go back and I am going to try to answer all these questions for all the questions that we never were able to get to. But unfortunately, it just didn't happen. To my surprise, I wasn't able to get back. Well, when I got back into Instagram to look at all the questions and stuff, they were gone. And I thought they would still be there, but I guess they just disappeared. So I apologize that we weren't able to get to all the questions that we had last week, but we'll try to remedy that this week. I want to talk about just, a little bit of something here that's kind of meaningful to me. And then we'll jump right into your comments and questions. I was thinking, I've been thinking, because I've seen some great folks come through this practice here in Colorado, and it's always just wonderful to be able to meet folks and help them to attain their dreams of a family. And I was kind of thinking back. You may notice, on one of these, a couple of these cameras, you can see there's a little birthday hat back on the wall there. I had a birthday last week, October the 4th, 10-4, good buddy, is my birthday. And gosh, I was thinking how fast this whole ride has gone. And it wasn't that long ago that I was having birthday parties at the skating rink, or mom was making a birthday cake, and that I was excited about being able to open presents with toys and all the things that we'd see advertised on TV, and the wish list, the birthday list that I would start to make 6 months ahead of time. Boy, the time just goes so fast. Wherever does it go? And I thought about it with my own family. So I have 3 children of my own, one of whom just got his driver's license, and he went to his high school homecoming game this past weekend. They got their butts kicked in the football game, or at least the varsity team did. My younger son, who's my middle child, actually plays on the JV team, and they won their game. But the varsity team didn't do so well this year. It wasn't long ago that I was holding that guy in my arms for the very first time, and looking at him with all the wonderment and amazement of what it's like to see your child for the first time, and to watch them grow up, and to see just how quickly it goes. It's amazing to me every single day. So I just wanted to share with you some of that love for those of you who have not yet had the great fortune of building onto your family. It is our pleasure to help you to get there. And you too will see that this time of dealing with fertility issues is such a roller coaster, and is so frustrating, and the things that we have to go through, and the indignities we all have to suffer in order to be able to help our families sometimes. This part will pass. This too shall pass, and then what happens in the future? Little people, little problems, and then big people, bigger problems, and life goes on. But we celebrate it really every single day. And if you saw my Instagram post yesterday, if you don't follow me, please do. It's Randy Fink MD. I said, on Monday, today is going to be a better day, because whatever happened yesterday, we have the potential to make today better, and tomorrow, honestly, even better than that. So thanks for being with me today, and thanks for riding along this ride. It's a pleasure to be here with you. Well, now, what else we got going on here? Let's see who is saying what. We've got, hi, to a special shout out to Brandis Montez, our wonderful nurse practitioner here at CNY Colorado. Susanna says, Susanna went through a very challenging time, because she had an IVF cycle and got some eggs, but all those eggs were immature. Every egg was immature. And what does that really mean? Well, eggs go through different stages of maturity, but ultimately we want them to be what's called an M2, which means meiosis 2. If you remember anything from high school, you might remember the word. And that's the stage that tells us that it's a mature egg that has the ability to be fertilized. In Susanna's case, all the eggs that she got were what were called GVs. They were germinal vesicle eggs, which are immature eggs. And we're thinking, scratching our heads, and we had a little Instagram back and forth earlier. The first thing I think of with eggs that are not mature is were you triggered a little too early? Did the eggs not have a time to mature? Was the size of the follicles not sufficient? In your case, Susanna, they were fine. That was not the issue. I think it really has to do with, when we get a lot of smaller eggs, they're usually coming, or immature eggs, they're coming from smaller follicles in the ovaries. A lot of times what happens is that the larger eggs, or rather the larger follicles, may not contain eggs at all. And so when we go to do a retrieval, every follicle we see, we're going to put the needle in it because we're going to try to extract something from it. We can't tell from looking at it whether there's an egg or how mature the egg is. My guess is that you had a bunch of smaller follicles, and that's where the eggs came from, that maybe the larger ones didn't have mature eggs. And so that's probably an issue of egg quality, and certainly something that we can talk about. But what a bump in the road, but I promise you it's not the end of the road. How about that? Hi to Lori Lorenzo on Facebook. And Tamisha said, I'm going for a frozen transfer. If I ovulate before I transfer, would it be canceled? So the process is there. And she asked, will I please explain the process of an embryo transfer? There's two different options when it comes to doing an embryo transfer. There is and a frozen embryo transfer. There is a medicated cycle, and there's a natural cycle. In the medicated cycle, and this is what we've been doing in IVF since IVF was invented. So for like the last 40 years or so, medicated cycles have been what we do. There is some estrogen that builds up the lining. There's some progesterone in the form of the progesterone shot, 6.5 days worth, and then you get an embryo transfer. Now, when we're giving you all this hormone, what it's doing is mimicking that which your body would do naturally. But we're trying to control every variable so that there are no ifs, ands, or buts about how things are going to happen. And when we're giving you this hormone, we're turning off your body's ability to make that hormone. So in theory, you should not be ovulating. If you do go to ovulate through a medicated frozen embryo transfer cycle, well, that generally means the cycle will be canceled because your body is trying to stick in some hormones there when we're already putting a bunch of hormones in, and it's just really going to confuse matters. Whereas with a natural cycle, or a modified natural cycle, which is what I favor, and I would encourage in most cases for you to ask about that if you haven't already. In a natural cycle, we're letting your body's own hormones contribute. A modified natural, which I'm becoming more and more fond of for several reasons, is where we give you some letrozole, which makes sure that your ovary is going to release an egg. And that letrozole, because of the effect that it has on estrogen, has what turns out to be a favorable effect on the uterine lining. So your egg grows and it grows, that follicle gets bigger and bigger as it's growing. That's where your natural estrogen comes from. That estrogen builds up the lining of the uterus as it does every other month that you're not trying to get pregnant. That lining serves as a spongy, warm, juicy place for an embryo to implant. When we see that the follicle is of a mature size, we can trigger your ovulation. Triggering it causes the ovary to release the egg. And when that egg gets released, that means your body starts making progesterone. Progesterone is the hormone that's required to keep the pregnancy growing. So we give you a little extra progesterone in order to supplement you on that, but that's in the form of vaginal progesterone, so you don't have to do the progesterone and oil shot. if you were to ovulate in a modified natural or in a natural FET cycle, that's what we want you to do. That's what we expect you to do. When you ovulate, that starts the clock ticking on when you're going to have your embryo transfer. But if it's in a medicated cycle and you break through the medication that we're giving you to suppress you, but to control all of those hormones, yeah, we'd probably want to start all over again. So best of luck there, my friend. Let's see. What do we have on the CNY side right here? Christina asks, would you recommend natural FET for my second transfer? First was fresh and failed. So, I want to mention one thing there, Christina. A lot of times I'll have a phone call with someone after they have had a fresh transfer that was unsuccessful, and they want to know, well, why didn't it work? Well, in general, IVF as an entity is a numbers game. It's about getting enough eggs to make enough embryos in order to be able to maximize the options, maximize the possibilities. So every time we place an embryo in, we're hoping that it will stick, but depending on what type of embryo it is, the odds may be against us. Now, it's still better odds than let's say home intercourse. So do you know what the odds are of getting pregnant? Assuming that everything works, assuming that the plumbing is all plugged in, assuming that the sperm swims and that the tubes are open and that the uterine lining is nice and normal, what are the odds of getting pregnant by having sex at home? Anybody know? Listen, I'm asking the question like somebody's going to answer. It's raise your hand. It's about 1% per cycle, which means we don't get pregnant every time we have sex. I mean, thank heavens. Now I know some people who are highly, highly fertile, and it seems like every time they can pass each other in the hallway and look at each other amorously and end up pregnant. But even those very fertile people, about 1% is the odds per cycle. Now with IVF, we can give you about up to a 60% probability per embryo. So the odds are so much higher with IVF. But let's say with a day 3 embryo, your odds are about 15% for getting pregnant with any one single day 3 embryo. Now, it's about 15-fold higher than it is for home intercourse. So, gosh, that's significantly better. If that's the kind of return you got on your stock portfolio, you would be very happy with that. But in the grander scheme of things, 15%, while being a lot more than the alternative of timing intercourse at home, is still not a very high pregnancy rate. So that's the most common thing that happens there. I do like the fresh transfer or the modified natural. Not the fresh transfer. Our odds are a little bit higher with the frozen transfer. But here at CNY, fresh transfer is included. And so if you have enough embryos and you can do it, absolutely do it. People get pregnant from a fresh transfer every single day. But if you're doing a frozen transfer, again, my preference is to do a modified natural if you can. The pregnancy rates are said to be at least equivalent and maybe in some studies a little bit higher. There is a lower risk of miscarriage and there is a lower risk of certain types of pregnancy complications that happen a little further on down the line. So that's my feeling about that there, Christina. Hopefully that helps. Tiffany Sunderland. Hello, Tiffany. My fertility workup is a little over a year old, but all was normal. My husband has a male factor, and that's why we need to do IVF. Well, I have to redo all my testing before starting IVF. There's some testing that we're going to want you to do, Tiffany, beforehand. So there's some hormone levels we kind of want to be able to catch up on. We want you to have your uterine cavity evaluated once a year. So if it's been more than a year since you had a saline sonogram or a hysteroscopy, I would recommend that you do that. We want to know where your AMH level is now, and certainly I want to know what your thyroid hormone is doing now. We look for that thyroid to be within a specific range to be considered optimized for fertility. So that's something that we'll end up testing at the beginning, like during the baselines of any cycle that you're starting. So let's see, does HCG start to slow down? This comes from my friend Maile. Hello. Does HCG start to slow down when it reaches 10,000? So in the beginning, God created HCG. HCG is the pregnancy hormone, right? So in the beginning of a pregnancy, that hormone level will double. But as it gets higher and higher, such as above 10,000, it will no longer continue to double. So yes is the answer to your question. It does slow down as the rate goes up there. Let's see, Samantha Simpson. Hello again from New Mexico. Hello, New Mexico. Colorado here. I have a question. How are people chosen for the grant? I've applied again, super hopeful. That is a very good question to which I have no idea. I could absolutely make something up. You have to send in a dance video, and whoever does the best plies. Oh, it does have to be, ballet. No, honestly, I just I don't know the answer to that. It's a very good question, and I'm sorry that I don't. But hi, Nikki Jones. We need to talk. And now that I see your name, I realize that we haven't. Mariah is asking, how long is one expected to bleed after a miscarriage and a D&C? I finally started to bleed about 10 days after the surgery and haven't stopped since. It's been since August, very light and spotty. So when we have a pregnancy loss, and I sure am sorry that you had to go through with that, and you have a D&C, what we're able to do there is we're able to remove what we call the products of conception. We're able to remove the pregnancy itself, but the uterine lining, which is called decidual lining, has to come out on its own. So oftentimes it takes some time for that to happen. And it's not uncommon that 10 to 12 days after a D&C or after a pregnancy loss, folks will have some increase in bright red bleeding, sometimes with cramps and clots. And that's really because there's almost like a scab inside the uterus where the placenta had implanted, and that scab starts to come off. And so a day's worth of some extra bleeding happens after that. If you are still bleeding now a couple of months later after a miscarriage and a D&C, I would consider that not a normal thing. And I think that that's worth getting looked at. There may be something mechanical on the inside. There may be a polyp that's bleeding, or more likely, it sounds like it is something that's hormonal that's bleeding. Like if you're not getting the right hormonal signals to grow a lining and then slough off that lining, you're not going to get a regular cycle. So I think a couple of months later, that wouldn't be a normal thing, Mariah. So I think that's worth looking into. Over back to the Facebook side of things, Leslie Lambden is here with us. Good afternoon. Before I had my tubes removed, Leslie asks, I used to become pregnant so easily. I had 9 kids naturally before I needed an IVF. Dang, yeah, 1% seems low. 1% is definitely low for you. When we look at fertility numbers, I'll put it this way, 85% of couples will conceive within 1 year of appropriately timed intercourse. But any one given cycle, meaning to say whether you are trying that cycle or not, 1% is about what you can expect in general from home intercourse. Now, as I said, there are certainly variables in there. And Leslie, you are a very impressive variable with 9 kids. So congratulations. And I think that actually means that you have your own baseball team, if I'm doing the numbers correctly. But Christmas must be very expensive at your house. I'll bet, but God bless you. Let's see. Does a frozen transfer increase the chances of complication for women with a previous C-section? I've read that it increases the chance of accreta. Well, I will tell you that IVF itself can increase the chances for abnormal placentation. So that is where the placenta implants. And anyone who has had a prior C-section is at an increased risk for having that kind of abnormal placenta. Now, Leslie, you ask about what's called a placenta accreta. A placenta accreta means the placenta itself is growing in to the wall of the uterus. So normally what happens is, let's say that this is the uterine wall. The placenta kind of sits here next to it. As the uterus grows, the placenta kind of moves along with it. But an abnormal placenta can grow down into the muscle. And if that happens, that can be a potential problem because that increases the risk for potentially catastrophic postpartum hemorrhage. So ultrasound has gotten very good at being able to identify placenta accreta, or an abnormally growing placenta. And so that for sure is something that we want to know before you deliver. Brittany is with us today on Facebook. Hi, Brittany. Thanks for being here. And Brittany loved watching Jody with me last week. Well, I loved having Jody last week. I don't know if Jody's still watching over here, but see there, you were very loved. It's nice to be appreciated, and that's a very nice thing, Brittany, for you to share. Thanks so much. Angelina Rodriguez is asking, after a third failed frozen embryo transfer, no immune issues. I did all the tests and had no issues. I have 7 3-day embryos left from being 46 years old, and I'm 47 now. What else is there to do? Well, I will tell you, Angelina, that is it's a frustrating position to be in. The embryos were created, if I understand, when you were 46 years old. The odds of having chromosomally normal embryos at 46 are unfortunately very low. So my guess is this is probably a chromosomal issue. Unfortunately, there is no good way to be able to look at an embryo to determine whether it's chromosomally normal. You could always try to grow those embryos to blast, have them tested. But my guess is that we would find they are not chromosomally normal. And that's, I hope that I'm wrong, but statistically, just simply based on age alone, that would be my guess. So the question that people ask is, well, is there something different I can do with my protocol that's going to change things? And I think, Angelina, you bring up a very, very good point. There's icing and there's cake. All right. The cake part is, do you have, or how are you getting your estrogen and your progesterone? Are you doing that through a medicated cycle? Are you doing that through a natural cycle? And in your case, you did fully medicated and also modified natural, I think you're saying. So you've run the gamut. You've tried different recipes for cake. I'm not sure that one is necessarily better, but again, I favor the modified natural if you can. The cake is the cake. The icing part is the autoimmune things that we put on that cake. And that's the things like the intralipid, the HCG wash, sometimes a PRP wash, the low-dose naltrexone. That may be the Neupogen that some people are treated with, the Prograf, the Plaquenil. These are the icing. Can you eat a cake without icing? Of course you can. I happen to think that icing on a cake is a better, happens to suit my taste a little better. Sometimes I'd rather eat the icing and leave the cake, but who am I to say? So I think as long as you're getting the cake, then we're dealing with a question of what's the situation with the embryo. And what we can do with that is really hope for the best there. So best of luck to you. This comes from looks like Mill Nair. I am 41 years old. I have polyps in the uterus and likely endometriosis plus chronic inflammation. Wow, you're running the gamut there, huh? A little bit of everything. I understand that endometriosis lowers the quality of eggs, and I also understand that having a laparoscopy before egg retrieval might damage some of the eggs. what would you recommend better? First, do the egg retrieval and risk immature eggs, or have a laparoscopy but lose some eggs? At 41, I would recommend 100% that you get your eggs first. Do your retrieval, make your embryos, and then and bank as many embryos as you can. Do as many rounds of IVF as you're able. Bank up as many embryos as you can get. And then once you're done with embryos, sort out your endometriosis, because endometriosis will have a much bigger, endometriosis can certainly have an effect on ovarian reserve. And you're absolutely right. If you have surgery and you start sort of digging around inside the ovaries, that will have some negative effect on your ovarian reserve, and you likely will lose some eggs as a result of that. So so I would suggest get your embryos first, make as many embryos as you can, and then think about having surgery or treating your endometriosis. Because endometriosis will also stand in the way of the way the brain is talking to the uterus and can affect implantation of your embryos. And so you definitely want to deal with that before you place the embryos back inside. Excuse me 1 second. I'm getting all choked up. Now, the other question that you asked there is about the polyps. Polyps in the uterus are little fleshy growths of the endometrium that can affect, that can be a herald of things going wrong on the inside. And so we definitely want to be able to remove those polyps before you do an embryo transfer. Now, sometimes, depending on which facility you go to, we can do a polypectomy at the time of your egg retrieval. So that's a hysteroscopy with a polypectomy at the time of egg retrieval. We do that in Colorado. They do that in Syracuse. They do not do that in Albany. They do that in Sarasota, and I am not so sure about Buffalo. So if you're doing your retrieval with us, then that may be a very reasonable option. But get your embryos first and then sort out the endometriosis. All right, what else is going on here? Bree Bales asked, do you recommend Lupron Suppression for those with endometriosis and adenomyosis? There's really 3 different medications, Bree, that we can use. One is called Myfembree. Myfembree is a once-a-day medication that you take orally. Seems to be very well tolerated, and that's usually the one that I recommend. There is Orilissa. Orilissa is typically a twice-a-day medication. And there is the Lupron shot, which induces a temporary menopause. With endometriosis and adenomyosis, we know that we can improve embryo transfer outcomes by suppressing endometriosis before for a period of 60 days. Now, it's not the case in everybody. And the example that I give, and if you've heard me say this before, please forgive me. But I can say, I can be taking care of a woman who wants to have a tubal ligation. She wants to have her tubes tied. And so we go do laparoscopic surgery to tie her tubes and look around. She's had, 5 kids and now wants to have her tubes tied. And she is covered in endometriosis. There's so much endometriosis. It's a wonder that she's ever able to even walk around, but she has 0 symptoms. Then again, we can take somebody to the operating room for chronic pelvic pain who sounds like they have just got awful endometriosis, but we look inside and they have one little spot. So what you see just doesn't always correlate. So you can have a lot of endometriosis and have that not have any effect on pregnancy. But if we know it's making a difference in terms of your implantations, if you're doing transfers, they're not working, and we know that you have endometriosis, suppressing for 60 days is really not a big deal. It's 2 months. That doesn't add a whole lot of time to the whole process. So I feel pretty strongly if we know that you've got endometriosis, adenomyosis, I think you do better by doing suppression. Let's see what else is going on here. Grace is, our donor is having her retrieval tomorrow. Well, outstanding. That is wonderful. Marcia from Miami has joined. And hello there, my friend. So great to see you. Dancer, thank you for the birthday wishes. Facing Destiny asked, is there a medication that I can use that helps with weight loss? So I would say the answer to that is yes and no. CNY does not do weight loss medication. I can certainly recommend Cheyenne Mountain Gynecology here in Colorado Springs. Cheyenne Mountain Gynecology can help you with weight loss through telemedicine. Semaglutide or Wegovy is really a brilliant medicine for weight loss. We've seen really just tremendous, wonderful results with it. It is usually not covered by insurance for weight loss, but it's a doable thing. The only thing is you're not supposed to get pregnant when you're on it. So and you're supposed to be done with it by 2 months. The current recommendation is 2 months before you get pregnant. We want you to be done with your Wegovy. So as far as I'm concerned, you can still do an egg retrieval on it. We just don't recommend that you do an embryo transfer while you're taking semaglutide. So Cheyenne Mountain Gynecology is one way to go there. You can look at the website. Ms. Roselle says 3 failed IVF transfers with PGT normal embryos and 1 blighted ovum. Does this give me a diagnosis of infertility? We are an LGBT couple. Well, I'm not so sure that, infertility is the first thing that comes to mind, but I think that, you're having implantation issues for sure with your fertility. So that kind of makes me wonder about things like, well, what's going on in the lining of your uterus? Because we know with those euploid embryos, you should have about a 60% probability of being able to get pregnant and roughly about 50% chance of an ongoing pregnancy. So it would make me say, when was the last time the uterine cavity was evaluated? Have you had a saline sonogram? Have you had a hysteroscopy? I would also think really strongly about doing a little biopsy at that time to make sure you don't have chronic endometritis. And then I'd really think about endometriosis, because silent endometriosis is something that can and does prevent folks from being able to get pregnant when they otherwise should be. And Ms. Roselle, you otherwise should be. The blighted ovum is an embryo factor. All right. So even though you had PGT testing, that's one of the limitations of PGT testing, and that is just not perfect. So again, with PGT, we're testing from the portion, we're biopsying from the portion of the embryo that becomes the placenta, which is not testing from the baby itself. So we can have a normal placenta and an abnormal embryo, and that's why it's not a 100% test. And it sounds like that was the situation there. So the blighted ovum is always going to be an issue that is related to the embryo, that's not related to mom there. But I certainly think, there's kind of a specific workup that I start to think about when someone should have been pregnant with 3 euploid embryos and hasn't been able to get there yet. Kaylee Clark is with us today. Good afternoon, Kaylee. Thanks for being here. Could use some advice. Age 27, I have PCOS and had a miscarriage at age 22. Started timed intercourse at 25 and did 5 rounds, got pregnant twice, and lost both around 8 weeks with no answers why. At what point would you suggest going to IVF? Well, so truthfully, Kaylee, you can go to IVF, at any point that you feel good about it. So one of the things that I would think of in that scenario is I would want you on metformin. Metformin is, of course, a medication that we use to treat folks who have diabetes. But in the IVF world, metformin helps with egg quality. And with PCOS, it helps to keep people, getting people to ovulate more regularly. But so you get a little bit of the benefit of helping to kind of tame some of the PCOS while also helping egg quality. But the other thing that metformin does for folks specifically with PCOS is that it decreases miscarriage rate. So I would 100% want to think, I think you should really be on metformin there. Now, if you were going to go to IVF, then I would say IVF, is always going to make sense because we're able to make an awful lot of embryos for you. I would test the embryos because given that the most common reason that folks will miscarry has to do with the fact that there's an abnormality in the embryo itself, usually a chromosomal problem with the embryo. So if we're able to test, albeit not perfectly, we're able to test the embryos to know which are chromosomally normal, we can increase the probability of pregnancy and potentially decrease the risk of miscarriage. Now, with pregnant twice, that's two losses. Usually after 3 losses, we start thinking about an evaluation for recurrent pregnancy loss, and there's some blood tests that we can do with that. And I would certainly, Kaylee, also want to take a look at the uterine cavity to make sure that there's nothing mechanical there going on, some scar tissue or something that could be standing in the way. So all the best to you there, my friend. Julia is with us as well. Good afternoon, Julia Cole. Last year I had a tubal reversal, 2 pregnancies quickly that ended in miscarriage, and my HSG showed my tubes are blocked now. I'm 42. Is IVF worth trying? The answer is, oh, hell yeah, IVF is worth trying because, first of all, we don't need the tubes. We're likely, depending on your numbers, likely to be able to make some embryos. Now, we are fighting the biology there at 42. It's harder for us to get pregnant, but 42 is not the same as 48. So, I would tell you at 48, it's virtually impossible to be successful with an IVF pregnancy, although it happens occasionally. At 42, I would say it's certainly worth looking at your numbers to see kind of where you stand. And I would say, yeah, for sure. I think it's worth thinking about IVF, especially, if you want to have a baby. And I'm guessing you probably do, or you wouldn't have asked the question. So good job, Randy, for thinking that one through. Oh, my heavens. Thanks, Julia, for being here. Carol is asking, is there evidence about which progesterone is better for a modified natural FET with a positive ANA? Do you think I need steroids or the antihistamine protocol? Okay, so there's different progesterones that we can use. The classic wisdom for progesterone has always been a medicine that's called endometrin. Not endometrium, but endometrin is a progesterone cream that has been on short supply due to some manufacturing issues from the pharmaceutical company. There's another medication that's called Crinone. Crinone is another progesterone cream that's used vaginally. Crinone and endometrin are both reasonably expensive. Crinone is not my favorite because folks tend to have a lot of bleeding, of vaginal bleeding when they're pregnant and using Crinone. It just increases the side effect of bleeding from the endometrium. And that's, of course, always a very scary thing when you're in the first trimester of pregnancy and have some bleeding. 50% of pregnancies will bleed in the first trimester, by the way. The other option is to use Prometrium. Prometrium is oral micronized progesterone is the generic name for it. And that's a natural progesterone that is designed to be used orally, but can be simply placed vaginally as well. That's often what we use because it is not expensive. It's frankly, it's cheap. Insurance typically will cover it. It's easy to use. Those are those little capsules that are shaped like an egg, and you just kind of tuck them on the inside. There are some specialists who feel very, very strongly about one methodology over the other. Some say, oh my gosh, you have to use endometrium. Well, endometrium's not really available right now. Or you have to use crenone. You can't use, or why wouldn't you use Prometrium? And Dr. Kiltz feels very strongly that if there's not compelling evidence to show that one is better than the other, then why pay more for something that isn't going to give you a proven benefit? So therefore, we often turn to Prometrium, but some of our docs will say, listen, I really want you to use, I want you to use endometrium. And so once it's kind of back on the market, I suspect we'll be seeing that a little bit more over here. I see my dear friends in Miami. Hello to everybody. And of course, the lovely and talented Amber Vince in Kentucky. My colleague Meg in Syracuse, head of our ORs. Hi, Shirley Anna. Nice to see you here. Eileen Bailey, who is in town here in Colorado for some exciting times. Glad you're having a good day. Let's see. Oh, hi to Zenaida in Miami. Journey to Baby W. Preparing for an FET. What would you suggest I do to prepare? Well, so there's some supplements that we recommend that you be on for a frozen embryo transfer. The first is a prenatal vitamin. The second is CoQ10 in the ubiquinone form. And when you're taking the ubiquinone form of CoQ10, it's 200 milligrams twice a day. If it is not the ubiquinone form, then it should be 600 milligrams total. So basically 200 milligrams 3 times a day is the easiest way to do that. What else? Vitamin D. I like you on 5,000 units of vitamin D. Vitamin D definitely has an impact on implantation. It's vitamin E and it's L-arginine. So that's the magic recipe from the book It Starts with the Egg as it pertains to the embryo transfer protocol. So I'd like to see you on all those things. Other than that, you want to kind of live as healthy as you can. We think diet is important. We think some exercise, getting some movement is important. Just living the best life that you're able to. I personally do think that cortisol levels are important as well. And what does that have to do? What is that? What is that cortisol thing? Well, that has to do with stress. Now, people ask me every day, does stress have anything to do with fertility? Does stress have anything to do with why this didn't work? Well, the answer is yeah, probably, but what can we do about that? I mean, we can't remove stress from our lives. It's just there. And, you think realistically, there are folks on the plains of Africa who don't have a roof over their head, nomadic tribes who are worried about getting attacked by other tribes or by wild animals or the insects that come out at night, and yet they're still able to procreate. So those are some pretty significant stressors. Yeah, I do think stress makes a difference. So, things like massage, acupuncture, traditional Chinese medicine, I think can make a difference. So those are the things that I would say it's certainly worthwhile to look into. Stephanie is asking, with this being my 3rd consecutive FET, should I do anything different medication-wise? Last 2, I only did estrogen and progesterone. Should I add LDN and prednisone? This is my last euploid. So I would say yes. You're talking about should you add some things in that are a part of the immune protocol? And I would say absolutely, because while they may not be helpful in the general population, there is some cohort of the population in whom they're going to help, and you may just be part of that population, Stephanie. Now, you did estrogen and progesterone, so it sounds like you were doing a medicated cycle. I would say, you know what, mix it up a little bit. Try a modified natural cycle, especially helpful in folks who have been unsuccessful with prior with prior medicated cycles. And of course, I'd still want to know, when was the last time you had your uterine cavity evaluated? And I hate to keep harping on that, but that is one of the things that people overlook. Oh yeah, I had my uterine cavity evaluated, in 2020 and it was fine. Things happen inside the uterus and they can happen pretty quickly. So once a year, we want you to be looking at that. So consider a modified natural and see if that makes a difference. Carol, Eva, Talise is saying, how about PIO? I have some friends who did both PIO, that's progesterone in oil, and vaginal. So when we are doing a medicated cycle at CNY, progesterone in oil is the most important feature. In fact, the data shows us that if you do a medicated cycle without progesterone in oil, you will have a significantly lower chance of being able to maintain a pregnancy. With a medicated FET, frozen embryo transfer, progesterone in oil is critical. Now, some people say, I just don't want to do that. I don't like that shot. And I'd say, I understand. I wouldn't like that shot either. But the outcomes will be significantly lower, and you just have to accept that fact. We use both PIO, progesterone in oil, and vaginal. So since we're providing all the progesterone, we really want to make sure that you're getting enough progesterone. So that's what happens there. In the modified natural or the natural, we're giving you progesterone. We'll do it vaginally. But if your levels aren't sufficient, because we still monitor these things, then we have to give you some progesterone in oil. So we have to increase those levels somehow. It's about 10 minutes until the top of the hour. We have about 10 minutes left here, Fertility with Fink and Friends. So glad to have everybody here today. What a great group. And these are really all great questions. And hopefully I'm doing a better job of getting some of them answered. Oh, let's see. Annabelle, I've had 4 abdominal surgeries. Both tubes have been removed. They found adhesions during my surgeries. Adhesions are scar tissue, and not surprising, after 4 surgeries, I would expect, yep, you're going to get some scarring there. Is there any treatment that can be done to aid an embryo to stick with adhesions? Well, I think you're talking about a couple of different things. The adhesions are inside the abdomen, and that's the uterus sort of sticking to the abdominal wall, the ovaries sticking to the uterus, the bowel sticking to the peritoneal surface. And that's what we think about when we talk about adhesions. You can have adhesions that are inside the uterine cavity, but that's a syndrome. That's a kind of a different, that's called Asherman's syndrome, and that's scar tissue inside the uterine cavity. If you've had abdominal surgeries there, Annabelle, my suspicion is that the adhesions you have relate to what's going on inside the abdomen, not so much inside the uterus. And the adhesions inside the abdomen should not affect the lining of the uterus and its ability to be sticky enough to maintain an embryo. All right, hopefully that's helpful there. Rakinar asks, how many days after a polypectomy can the transfer be done? So if you are going to have a hysteroscopy and a polypectomy, we want you to do that in a cycle where you are not having anything done to the uterine lining. We don't want anything touching that lining because it needs to be a pristine environment for that beautiful little embryo. So if you're doing a hysteroscopy, you do that at least in the cycle before. Then you get a period at the end of that cycle, and typically in the next cycle, you can generally proceed with doing an embryo transfer. All right. Faith Waring is asking, I'm closer to the Colorado Center, but my consultation is with a doctor who's based in Syracuse. Why would that be? Will he be the one performing the treatment? No. If you're coming to Colorado, it is likely to be me that's performing the treatment. So it's because, if you request to have your consultation with one of the Colorado providers, CNY does its best to accommodate. Sometimes the scheduling just works out that you can talk to one of the fertility specialists who will set up a protocol that is consistent with what we do in CNY system-wide. So, we try to be as as open as we can to everybody, just get folks in as quickly as possible. But sometimes that means you'll talk to a provider who's in a different office. If that's an important thing to you, you just simply have to ask the call center to say, hey, I would, my preference is to speak to someone in the office where I'm going to have my treatment, but it may mean that you have to wait a little bit longer just because schedules, kind of being what they are. Let's see what we got here. With IUI, exotensil, I like it. With IUI, what is the probability that it will work? And IUI typically has about a 5 to a 9% probability of success per cycle. So again, IUI there is anywhere from 5 to 9-fold greater than home intercourse. So it does help to get out the best and the strongest sperm and to place them inside at just the right time, so it maximizes the opportunity for them to be able to reach an egg. Now, again, IVF is always going to be more effective, but certainly an IUI is less invasive. It's less costly. And I think it's fine to do depending on how old you are, if you have the time. But I wouldn't want, one of the things that concerns me sometimes is that I'll do a consult with someone who would like to do an IUI. And we set up a plan for them to do that IUI. And then I don't hear from them again until, maybe 9-10 months later, and they've just kept doing IUIs. And so I always try to warn people, each IUI that you do is, it costs money, obviously, and more importantly, it costs emotional capital. So every time that you're doing it and you're watching the calendar and you're watching the clock, and then at the end of that month, you get a period, it feels like, you have failed that month. It takes its toll. And so you'll reach a point eventually where you will have spent about as much money doing IUIs as it would have cost you to do a round of IVF, which is going to give you a, exponentially higher rate of pregnancy. So I just tell people, listen, if it hasn't worked after about 3 rounds of IUI, maybe really think about, is that the right choice to keep doing? Let's see. If an FET cycle is canceled, what costs carry over? Do you lose the monitoring and transfer fees paid? That's a good question there, my friend, and I don't know the answer to it. The cost department is kind of outside my wheelhouse, so I don't have a lot of experience in knowing about that. But I would simply portal message the patient accounting department or one of the front desks at the office where you do your procedures, and they'll be able to answer that question for you. Accounting sometimes is slow to reply, but if you ask, send it to, for instance, if you're a Colorado patient, send it to Colorado front desk. The folks at our front desk are the instrument of the accounting department, so they will have the answer to that. Oh, let's see. My girlfriend just got 1 mature egg, and we were told it was excellent quality, but even with ICSI, it had a late fertilization and didn't divide. Second time this has happened. Our test had come out perfect. So that may be a sperm issue there. And so late fertilization kind of means, well, we don't know if that's because we just don't see it fertilizing or if it's actually late in fertilizing, but either way, it can decrease the outcomes. And if it's not dividing, that makes me think that either 1, there's an issue with egg quality, or 2, that there's an issue with sperm. One of the things that you can do for sperm in that situation is a procedure that is called Zymote, which we've talked about before, ZYMOT, and it's an add-on in our lab that helps to select sperm that has lower degrees of DNA fragmentation. In other words, better sperm. So if you'd like to take a look at the Zymote website, I think that's a reasonable thing to do, but it's probably also worth talking about what can we do to improve egg quality in that scenario. Let's see what else we got here. Raven Lovejoy, I have vaginal and shots right now, and I'm 5 days post day 5 transfer, hoping that it works. So you're getting ready to do your midways, and at day 10, we will have your positive pregnancy test. How about that? That sounds like a very good plan to me. Hey to Brickle Barbie, nice to see you with us today. Erica Walden, I would recommend people getting a needle guide assistant to take your PIO shots. It makes things so much easier to do yourself. And, I think that's definitely true. There was and I can't remember, there was a company that made those needle guides, and somebody told me once, and I talked about it on one of these lives, and now I can't remember. I'm pretty sure you can Google it. But yeah, I am told also, thanks for that, Erica, that using the needle guide for the progesterone and oil makes that shot much easier. Well, guess what? It's top of the hour, and unfortunately, we are out of time for a Tuesday. So I want to say to all, thanks again so much for being with me here with Fertility with Fink and Friends. Thanks for being my friend. Please follow me on Instagram. It's Randy Fink MD. Try to put out some fun things, some entertaining things, and also some things to help with knowledge and to bring us all a little bit closer to getting where our hearts desire. So remember, fertility is not your novel. It ain't your book. What do I mean by that? It's just a chapter. And what are we doing? We are here to help you rewrite that chapter. So until next Tuesday, thanks again so much. Dr. Randy Fink saying, God bless and good night.